Yeah, I could. This one is letting me let me paste.
Yes. Okay, before just giving, you can see the answer. Okay, first give the answer.
Oh, sorry. I'm sorry. Let me let me close it. Wait, what is it? Yeah, right here. Asymptomatic 32 woman. Now everything is there. With HIV infection comes to the physician as a new patient. Her last visit to a physician was 14 months ago. No medications. Exam shows hairy leukoplakia and cervical adenopathy. CD4 count 180. HIV plasma viral load is 20,000. In addition to antiretroviral, which of the following most appropriate next step in management?
CD4 count is less than.
Did she need a mammogram? Mammogram is from what year? Mammogram is 30. She's 30, so maybe mammogram. And pap smear, maybe she needs all of it. I don't know. Okay, ready?
Yes.
Okay.
Tap
Oh,
and
okay.
zero VC.
Jesus. I knew she needed a Girovesi, but I was like,
Yes,
"Hmm."
they actually include tap to distract us. Okay. This patient is a 32-year-old woman with AIDS, which is defined as having a CD4 T lymphocyte count that is less than 200. AIDS, a CD4 T lymphocyte count that is less than 200. Prophylactic opportunistic infection such as pneumocystis and Mycobacterium avium intracellular infection should occur for certain CD4 T lymphocyte count threshold less than 200 millimeter cube for pneumocystis zero VC prophylaxis and less than 50 millimeter cube for Mycobacterium avium intracellular infection. Given these patients, CD4 T lymphocyte is 180. Prophylaxis of pneumocystis zero VC is warranted. Additionally, patients with HIV and AIDS must be screened and treated as in general population. Okay,
when is the for the pap smear for the cervical cancer? When is the screening again?
I don't remember actually.
I don't remember also. Okay.
N- Now you can see the Gemini, like you can see the answer or not. You got my point.
Yeah,
I, I know
I
I
guess.
doing this a lot, but it sometimes help.
No, it does. I like their explanations. Okay, let's see if it lets me do it. Though. I don't know why it's pasting the question like this. Uh-uh.
They are saying wrong. Sometimes it happen. I have said you yesterday. It is not that I am advertising.
Similar to be the plasmid is important but less urgent than PCP. What?
This is confusing actually. This question actually in at a first glance, uh, you will choose pneumocystis zero Veci.
Yeah, I mean, I guess the mammography doesn't make sense because she doesn't have a no nodule or something. So okay, fine, no mammogram. But why the pap smear?
Okay, cervical cancer screening start
Mm-hmm.
at age 21 to 29, like cytology every 3 years.
You said 20 what? Say it again.
21 to 29. Before 21, no screening is needed. But after 21 to 29, cytology every three
Let me
years
She's 30 something.
Sorry.
She's 32.
So I think that we should.
No, you said 21 to 29.
Yes, cytology every 3 years in 21 to 29, and in age 30 to 65, cytology every 3 years, or cytology plus HPV testing every 5 years, or
Okay.
like find out the cervical cancer screening in the
In what?
in what can I say?
In
Mm,
here in a
in
circle.
yes,
I'm trying to find it, but it's HPV can give starting from 9 to 26.
this is for vaccine.
Oh, the
They
vaccine
are
is on
for
nine.
screening. We are looking for the screening, isn't it?
Yeah, but
So HPV is like the cervical cancer screening, isn't it?
HPV is the vaccine. Yeah, the screening is pap smear, and the vaccine is the HPV vaccine.
Yes, and we are doing this for cervical cancer.
Yes, we're doing it for
Main,
cervical cancer. Yeah.
Mainly the cervical cancer. There are other
Uh-huh,
things also, but usually we do this for women with the cervical cancer, isn't it? So in case of cervical cancer, screening start with 21 to 29, like cytology every 3 years, and age 30 to 65, cytology every 3 years, or cytology plus HPV testing every 5 years, or primary HPV testing every 5 years. And age more than 65, no screening if negative prior the screen. Okay, that's the
uh-huh.
box I'm talking about. Talking.
Mm-hmm. So
So
basically,
yes, the timeline is 21.
21, let's say just say 21 to 65.
Yes,
Let's just
21
say
to 65. Yes,
every
that
3
would
years.
be easy.
Okay. Okay. Jeez. Fine.
Sorry. Hypoxemia is the primary mechanism for development of pulmonary hypertension due to chronic obstructive pulmonary disease due to potent vasoconstriction induced by hypoxia. Chronic hypoxia leads to vascular remodeling, leading to chronicity, elevated pulmonary vascular resistance, and pulmonary hypertension. There is remodeling leading to chronically elevated pulmonary vasculature and pulmonary hypertension. There is direct correlation of the severity.
Are you still
Sorry.
there?
So yes,
Oh.
there is a direct uh, there is direct correlation of the severity of the hypoxia and development of the pulmonary hypertension. Severity of hypercarbia in patients with COPD in patients with COPD has not been associated with the development of pulmonary hypertension, nor has the severity of the obstruction or elevated residual volume, while the decreased cardiac output can lead to pulmonary hypertension secondary to left-sided heart failure. This is not the most likely mechanism of pulmonary hypertension in this patient.
This is
Like
hypox.
I can understand the last point. Like decreased cardiac output can lead to pulmonary hypertension. Okay, lead to pulmonary hypertension if it is left-sided heart failure.
Mm-hmm.
Okay, got
Mm-hmm.
it.
57 men comes to the ED because of painful cold right leg for 4 hours. He has hypertension, diabetes, hyperlipidemia, medication, metformin, thiazide, torvastatin. He smoked for 40 years. BP high. Pulses are decreased in the right lower extremity. Creatinine is high. Angiography of the right lower shows occlusion of the common femoral artery. 24 hours later, serum creatinine increases. Which of the following measures prior to his angiography is most likely to have prevented this patient worsening azotemia.
Okay.
Ready.
Yes. It's hydration. It's contrast-induced nephropathy is defined as acute kidney injury developing shortly after the exposure of the IV contrast. IV contrast patients with CKD are at significantly higher risk of developing CIN. Multiple studies have looked at pretreatment with IV fluid to reduce the risk of CIN, with similar results with both sodium bicarbonate and normal saline. Treatment with N-acetylcysteine has also been studied but has not shown to reduce risk. Metformin clearance is impaired in the setting of CKD, which may lead to lactic acidosis, which has significantly increased the risk of mortality. Acute CIN leading to worsening renal failure and further impaired clearance may further exacerbate this. However, metformin use alone has not been associated with increased risk of CIN, so discontinuation of the metformin would not likely decrease incidence of CIN itself, but would limit the complication. Okay.
62 woman, physician because of increasingly severe pain of the fingers over the past 6 months. She has 6 year history of cold sensitivity of the hand. On cold exposure, finger become pale and then turn blue, and then there is redness with recovery. She has 3 year history of GERD. Exam shows tightening of the skin of the fingers, erythema, scaling, and telangiectasia. Dry, crepit, and crackles are heard in both lungs. X-ray of the hand shows loss of tufts of some distal phalanges and scatters soft tissue calcification. Serum antinuclear antibody test is most likely to show which of the following. Here's what scleroderma
Yes.
anti-nuclear.
Limited, isn't it? CREST syndrome, limited variety of scleroderma.
Yep.
Okay.
What is anti? Oh, okay. I guess we'll read it here.
Anti-U1-RNP MCDD.
MCDD.
Okay, this patient has symptoms of systemic sclerosis, particularly Raynaud's phenomenon, sclerotic telangiectasia, and is likely systemic sclerosis. Serology in this patient will typically show anti-nuclear antibody is also typically positive, and anti-HCl70 is usually positive in this patient with diffuse cutaneous systemic sclerosis. It is not likely that serology would be negative in this patient. Anti-neutrophil cytoplasmic antibody may be elevated. Anti-neutrophil cytoplasmic antibody may be elevated in patients with vasculitis, GPA, microscopic polyangiitis, or eosinophilic granulomatosis with polyangiitis. Anti-RNP ribonuclear protein antibody is usually positive in mixed connective tissue disease with overlap of symptoms of lupus, systemic sclerosis, Sjogren's syndrome, polymyositis, and dermatomyositis. Polymyositis patients typically present with fatigue, low-grade fever, myalgia, and arthalgia. Given that the patient has symptoms more consistent with systemic sclerosis alone, RNP is not likely to elevate at this time. Okay.
62 men comes to physician for pre-operative evaluation. He's scheduled to undergo partial colectomy in 5 days because of recurrent diverticulitis. He can carry groceries up to 2 flights of stairs without stopping. He has no history of chest pain or heart disease. 2 months ago, his serum cholesterol was 162. He takes no medication. He's adopted and has no. Let me look at the cholesterol. 162 is fine. He's adopted, no information about his family health. He smoked for 30 years but stopped 3 years ago. His BMI is, I guess, fine. Pulse is fine, regular BP, that's fine. Lungs are clear. S1, S2 fine. Grade 2 out of 6. Holosystolic murmur heard at the apex with radiation towards the axilla. Abdomen is soft. ECG, normal sinus rhythm, and the left frontal branch block. Echo shows mitral valve thickening with mild regurgitation. Which of the following diagnostic text is indicated prior to the operation? Oh. Hmm. So he has mitral regurg. I'm not sure. Oh my lord. Ready?
Yes. Okay, this patient, the patient is a man with obesity undergoing elective surgery. Pre-operative evaluation are to risk stratify prior to undergoing operation and detect problems that may override the need of surgery. The patient has a good exercise tolerance, manifests by walking 2 flights or manifests as walking 2 flights of stairs without breathlessness, and has a number of cardiovascular risk factors. He has two he has grade 2 by 6 systolic murmur, typically a grade of 3 by 6 higher would suggest the pathology. Mm, and as such, the patient has no signs of angina or cardiovascular decline. None of the diagnostic studies listed would change immediate management prior to surgery or require further testing. Would not require further testing. Okay.
Okay. Okay. 52 woman comes for routine health. Uh, she feels well. Over the past 6 months, menses have occurred. Irregular 2 to 3 months intervals, no medication. She has smoked for 30 years. Not that much drinking. Father hypertension, mother osteoarthritis of the knees, and is scheduled for bilateral knee replacement. Patient BMI is fine. Pulse is fine. Regular blood pressure is fine. Range of motion of all joints is full and does not produce pain. She's concerned about her risk of arthritis. Uh, mm, which of the following is most likely to decrease this patient risk of osteoarthritis?
Decrease the risk of arthritis.
Osteoarthritis. Hmm. Ready?
Okay, yes.
Probably not that.
Okay, weight loss. Osteoarthritis is the manifestation of the stress on the joints over a long period of the time. Of all options listed, weight loss is the best modality to reduce stress on the joint. Exercise, particularly load-bearing exercise with weights, is a good prevention strategy. Neither walking or nor swimming provide that. And smoking is a risk factor, but quitting at this stage in a patient at the onset of the menopause would have less effect on and is more impact on the bone. Okay,
Okay, so weight loss is for osteoarthritis and smoking is for osteoporosis.
yes.
And okay. 42 men with comes to the ED because recent onset shortness of breath. He has smoked for 25 years, emaciated. Huh? He's emaciated
Emaci-
and moderate. I don't know what that means. And in moderate respiratory distress. There is
Emaciated
dull.
means like he his physique is not good. Like he
Oh,
is, you got
skinny.
my, yes, skinny. You can say
Okay.
it.
Okay. There is dullness to percussion and egophony at the right lung base. He has leukocyte count that is high. I believe neutrophils are high and everything else is normal. X-ray of the chest shows right lower lobe infiltrate with pleural effusion. Thoracocentesis shows purulent, foul-smelling fluid. Diagnosis.
Okay,
The neutrophil is high. Neutrophils is the one that is high. Neutrophil is actually normal. Never mind. And bands are high. Anaerobic empyema, tuberculosis, pneumococcal, and there is lobar, and it's foul smelling. Okay, ready.
okay. Anaerobic empyema is the correct answer in this scenario. The acute onset shortness of breath accompanying the right lower lobe infiltrate and leukocytosis makes an infectious etiology of the pleural effusion more likely. The presence of pleural fluid is a diagnostic of the empyema, while pneumococcal new empyema is one of the most common cause of community acquired pneumonia. The foul smelling nature of the fluid combined the foul smelling nature of the fluid combined with the location of the pneumonia in the right lower lobe make aspiration pneumonia from an anaerobic organism more likely.
Yeah, can you read E? The tuberculosis.
Yes, tuberculosis empyema is uncommon, especially in the absence of the risk factor or in the absence of risk factor organism more likely. In the absence of the risk factor for TB, and is usually seen when a cavity lesion, typically located in the upper lobe, rupture into the pleural space, causing hydronephrosis. Okay.
62 men admitted to the hospital for treatment of pneumonia. He has 3-day history of fever, cough, productive of greenish sputum, mild shortness of breath. He has type 2 diabetes, coronary artery disease, medication, aspirin, atenolol, whatever, glycoside, metformin, glitazone. He appears ill and has mild shortness of breath. Temperature is high. Pulse is high regular. Respiration high. BP high. Noise crackles are heard at the left lung base. Labs. Leukocyte count is high. Neutrophils high. Bands normal. Leukocyte normal. Sodium normal. Potassium normal. Chloride normal. Bicarb. Hello. Glucose gets high. Creatinine high. AST normal. X-ray of the chest confirms left lower pneumonia. Oh my goodness. Left lobar pneumonia. Immediate discontinuation of which of the following is the most appropriate next step? Discontinuation of what medication to stop the pneumonia?
Immediate discontinuation.
I have no idea.
Bilateral.
Glycogen.
Low.
Ready?
Wait 1 second. Okay,
Probably not right. I feel like it's aspirin. Oh no, it's metformin.
that I should look at the creatinine. Creatinine more than 1.4 metformin should be stopped.
Mm,
That's the thing I'm missing. Okay, so this patient this patient has pneumonia with elevated creatinine. This patient has pneumonia with elevated creatinine, indicating this patient has pneumonia with elevated creatinine, indicating acute kidney injury. Metformin is mostly excreted by the metformin is mostly excreted by the kidney. In the setting of the renal impairment will accumulate in and increasing the risk of potentially fatal lactic acidosis. Therefore, metformin should be discontinued at this time. Given that the patient is hypertensive and it would be inappropriate to discontinue atenolol or isosorbate dinitrate at this time. In fact, may require antihypertensive therapy in the setting, and glipizide and rosiglitazone can be continued at this time for blood pressure. Okay.
72. Oh. Woman comes to physician because 6 day history of 6 day history of increasingly severe left hip pain. Okay, she now has difficulty walking because of the pain. She has temporal arthritis and hypertension. Medication, prednisone and alapre. Vital signs normal. Internal, external range of motion of the left hip is limited by pain. Reminder of the exam is fine. X-ray of the left hip shows no abnormality. MRI of the hip is shown. Diagnosis: left hip.
Okay, I got it.
How you got it so fast? Let me see. Trochanteric bursitis. Vascular necrosis. Don't look like a vascular necrosis.
Why
Mm,
not?
because I thought here they will be like
Look
more.
at this patient has temporal arteritis, and for temporal arteritis, he got prednisolone, and prednisolone cause
Oh,
and in this MRI there is crescentic shape, look like crescentic shape on
but
the
here
yes.
don't look. Okay, I guess. Yeah.
It's my
Okay.
thought. I am confidently give wrong answers.
Very confidently. You're right. You're right. Yeah.
That is the problem. That sometimes helps me, but that is the problem of me. Like when I stick in any point, I fail to exclude the others. Okay, so this is a patient on prednisolone with hip pain and X-ray show no findings, making it a fracture and osteoarthritis unlikely. She has lucency in the femoral head on the yeah, femoral head on the left, compared to the right, making avascular necrosis the most likely diagnosis. Making avascular necrosis the most likely diagnosis. And iliotibial band syndrome would have lateral leg pain, likely after physical overuse, and is less likely. And trochanteric bursitis would have tenderness along the greater trochanter. Both of these might be seen on MRI, but are usually diagnosed clinically by the examination and would not show the MRI finding seen in this patient. Okay.
Okay. Study conducted to compare new. Oh my lord. New stool. To compare new stool test with mucosal biopsy.
We sometimes forgot there is
Ugh.
biostat.
New stool test with mucosal biopsy for diagnosis of H. pylori infection. Total 400 patients with suspected H. pylori are enrolled. Okay, patients are screened using both methods. Results show that 100 patients who tested positive for H. pylori infection on biopsy. So, wait, the results show that 100 patients who tested positive for H. pylori on biopsy, 80 also tested positive using the new stool test.
100
And
patient.
120 patients who tested negative on H. pylori infection on biopsy tested positive using the new stool test. Oh, Lord. Which of the following represents sensitivity of a new stool test for H. pylori infection in these students in this study? Sensitivity is people that
100 patient tests positive for H. pylori on biopsy, isn't it? Like it is true positive.
100 people this one can also
And 80
test.
also test positive in the new stool test.
Okay, so it also tested for so 80, and then the people sensitivity is like you have the disease and you test positive for the disease. Um, so it will be 80. I mean, I'm thinking. I mean, I know it's too easy to, but I'm not gonna try to overthink. I'm not gonna try to think that much on this one. Ready?
Wait 1 second. And 80
Don't
also test.
overthink. Or maybe I'm wrong. So
Okay,
sensitivity is too positive over too positive for
plus
it
false negative, isn't it?
was false negative. So it will be 80 over 80 plus what is false negative? Who tested negative
120 patient who tested negative for H. pylori on biopsy.
and biopsy tested positive. So that's false negative. When you say it was two positive or two positive for plus what?
False negative,
False negative.
isn't it?
Is it? You asked. I thought you knew.
Yes, I know it. I know it.
Okay, okay. So it will be 80 over 80 plus 8 plus 120. So it will be. Let me see if it gives me something different. With 280 over 200. It gives me 0.04. So it gives me 40. Hmm.
Maybe.
Okay, yeah, it's 40. It's probably 40. Oh my God, I have to remember those things. Anyway,
Let's see.
yeah, it's
You
40.
are right.
Pretty. No! Oh my God. I was, oh my Lord. Oh my.
Okay, so what's the wrong in the calculation? This is the wrong. 80 by 20, like 100 patient. We like there are 400 patient, isn't it? 80 by 20 is 100 and not positive is 300. You got it. You got the clue.
No. So you say, no,
So
I don't know.
look, wait. 80 also test positive in the new stool tools.
Okay,
Eh,
we know true positive is 80. We got that part.
yes.
Okay.
Okay. And the
How did they
false
find?
negative is,
Uh-huh. Mm-hmm.
and the true negative is,
No, we're trying to find false negative.
yes, we
You said.
tried.
Uh-huh.
Okay.
So how did they find 20 here
Because
for false?
100 patients were tested for H. pylori infection on the biopsy. From the 100, 80
Mm-hmm.
test positive with the new stool test. So rest of
Mm-hmm.
the 20% is false negative. You
You
got
mean
it?
you mean false positive? That would be false, but that wouldn't be false negative. That would be false positive.
No, no, that is false negative.
Oh my god.
That is the confusion. So we need to put the things into the box. Wait, think in this way, like 100 patients of the 100 patients of the 100 patient who tests positive for H. pylori on biopsy. Okay, total
Mm-hmm.
is 100. 80 is true
Mm-hmm.
positive.
Mm-hmm.
The remaining is 20. And according to the like Randy Nail, like sensitivity goes down. So 80 goes down. You got my point. Like
Mm-hmm.
80 divided by 80 plus 20. That's how they calculate. And specificity goes up. And in the, if you want to, okay, tell me the specificity of this patient.
It would be like
180
80 over.
divided by 180 plus 120, like 180 over 300, isn't it?
Mm-hmm.
Into 100.
Mm-hmm.
So 3 and 60%.
Woo! No, that's not.
Look at the specificity.
Where do you see it?
Oh, they haven't given. So if you
No,
want to find the specificity, so specificity is 60%.
no, I prefer to think about it like the way I thought it because there's no way you're gonna have time to do all these calculations, all these things. I mean, I guess you. I mean, if you.
You need to make a box for
Yeah, that's what
doing
I'm.
this, but
No,
otherwise
no,
you cannot. Okay,
no. I think it's
you,
easy the way
yes, it's easy, but
the way I thought.
we have done wrong.
No, I think that's how I found it because I found N 80 first. It's just the
How?
number. It was
Like
just
80 divided by 100.
no. It was just like sensitivity is the number of people that have the diseases and test positive for the disease. So it will be
80. Oh,
just
okay.
80. That's how I found 80. But then when you brought the formula, I was like, okay, maybe I need to use the formula. I was like,
No, no,
but I
no.
was
In here, they specifically said that's why you start thinking on that way. But most of the time, you need to have those
like,
formula.
this is yeah,
I
this is
know I am very bad in biostats, so for me,
oh
you
god,
have done wrong.
oh, this is
You
horrible.
are almost, you are, you are almost ready, but I to drag you in different direction. Okay,
47 woman comes to physician because 2 day history of soreness in the back of her throat and pain on swallowing. She has had recurrent episodes of tonsillitis during the past 2 years. Exam shows massive edema of the soft palate and enlarged tonsil with purulent discharge from the right tonsil. Without treatment, this patient is at increased risk of which of the following? Edema of the soft palate
is it the
enlarged.
complication of the tonsillitis?
I'm thinking purulent discharge. Where we compromise? In between airway compromise and brain abscess. Airway compromise and brain abscess. I'll just go there. Okay, ready?
Yes,
Okay.
right. Okay. Okay, this patient has a history of recurrent tonsillitis along the edema of the soft palate, and the unilateral purulent discharge. Edema of the soft palate and purulent discharge raises suspicion, raises concern of peritonsillar abscess. Without appropriate treatment, which may include either incision and the drainage or needle aspiration, progressive swelling may lead to airway compromise. The most common causative organism is group A Streptococcus. Other complications of peritonsillar abscess include aspiration pneumonitis, lung abscess, hemorrhage due to septic necrosis in the carotid sheath, and extension into the deep neck tissue or posterior mediastinum, and post-streptococcal sequelae such as rheumatic fever and glomerulonephritis.
Oh, I did not see that coming. So brain abscess is not a complication.
Yes, brain abscess. Brain abscess is for what?
It's
Which
for, I feel
complication?
like
I think that otitis externa,
otitis. No, external. External don't have it's otitis
otitis
media.
media, media. Yes, maybe
Yeah.
otitis media.
Okay, okay. I did not see that. Okay. Previously healthy 27 intern comes to ED 5 minutes after she was stuck in the middle finger with a uh, 20 gauge needle used on a 22-year-old patient with AIDS. The patient is currently being treated with zidovudine, indinavir, lamivudine. His current plasma HIV viral load is undetectable. Patient serum studies 2 days ago showed total bilirubin is fine. AST, I believe AST is high. Let me double check. Here is high. ALT is high too. Hep B positive. Hep B
Surface
antibody
antibody is positive.
positive. Antigen is negative. Uh, the intern had completed Hep B immunizations 10 months ago. Exam shows a needle puncture wound. In addition to chemoprophylaxis for HIV exposure, which of the following is the most appropriate intervention for the intern?
Should we give immunoglobulin?
Should we? I don't know.
I don't think so. He's
Uh, maybe,
he
yeah,
have
because
got
we
the
know.
antibody, or like antibody is positive.
Yeah. Okay. Ready?
Okay, I don't know. And
Oh Lord Jesus. Yeah, nah, we were like so
he,
off.
thinking, I was
Mm,
thinking that
mm,
a very weird answer will come.
mm.
So in the setting of the needle stick injury, the first priority should be to clean the affected area, with soap and water. This patient should be followed by this patient should be followed by seeking medical treatment, and each healthcare facility has a protocol needle stick injury protocol that should be followed, and recommendations are available through the CDC as the patient is hepatitis B surface antigen negative. No post-exposure prophylaxis for hepatitis B is required. This would also be the this would also be the case if the patient has documented anti-HBs level more than 10 milli-international unit per ml after completion of the hepatitis B vaccine. Interferon alpha be indicated for the treatment of for acute hepatitis B infection vaccination. Interferon alpha. Okay.
72 men comes to physician for routine. He has a 1 year history of hypertension controlled with thiazide. He smokes. He smokes. Drinks alcohol a lot daily. He has gained like 13 pounds since his last visit like a year ago. Weight, BMI is fine. Blood pressure is high. LDL cholesterol, let me take my notes. LDL cholesterol is, where am I? 150 is fine. HDL is fine. And which of the following is the greatest risk factor for coronary artery disease in this patient? LDL is actually fine. Like this is just a question that you
His
know
blood
you don't.
pressure is pretty much high, isn't it?
Coronary
Does
artery
it
disease.
diabetic?
No, I think this is just a question of the concept. It's not like,
Okay.
I'm not sure. Was it cigarette? Was it blood pressure? Coronary artery disease. Okay.
You were right.
Yeah, this is a concept question. It's not about the that you actually didn't need to read the whole the thing. It's like a concept question.
This patient has a 72-year-old man with multiple risk factor for heart disease. Although blood pressure and obesity contribute the risk for heart disease, the patient history of cigarette smoking is far and away the biggest risk factor for cardiovascular disease. Excess alcohol consumption may lead to blood pressure elevation and thus may also be a risk. Hydrochlorothiazide is used to treat blood pressure and has been shown to reduce cardiovascular risk.
Yeah, it's just the concept. They say that I think it was for coronary artery smoking, then
Sm-
for stroke is hypertension, and for AAA is
Cigarette
oh,
smoking,
no, it was it the atherosclerosis or was it the cigarette? I forgot, but it's like it's like a concept. It's not like I
that may,
forgot.
oh, I need to remember it.
Yeah,
Like cigarette smoking goes with the hypertension always,
no,
but
cigarette.
usually as this patient has only 1 year history of hypertension, that is the clue. Maybe that hypertension
No,
is not the risk factor for now.
no. It's a concept. It's like Divine has it. It says for stroke is always hypertension,
Okay,
for coronary artery disease is always smoking, and then for AAA is always I forgot if it was smoking or if it was atherosclerosis. It's like I don't know. If I find it again, I'll but I know
okay.
like Divine put emphasis on that. 24 woman gravida 2 para 2 comes to ED because of uncontrollable nosebleed for 6 hours. This is her fourth nosebleed over the past two weeks. Each of the previous nosebleeds stopped within approximately 2 hours. Menses are regular 28 days interval, but she did have heavier than usual bleeding during the last two menstrual periods. So
Abdominal
she's
aortic aneurysm risk factor is smoking.
smoking
Advanced,
too.
yes,
Uh-huh.
advanced age, smoking, male sex, hypertension. But smoking is earlier. Okay,
Okay,
management.
so which is atherosclerosis? Is it the stroke? Okay, okay.
There are like in thoracic aortic aneurysm. Okay, no.
Okay, in the stroke, which one is the most important for stroke?
Stroke is hypertension.
Hypertension. Okay. So I guess that's what we need to remember. Okay.
Okay.
Well, she's not pregnant. Gravida 2 para 2 comes to the ED because of uncontrollable nosebleed for 6 hours. This is her fourth nosebleed over the past 2 weeks. Each of the previous nosebleeds stopped within approximately 2 hours. Menses are regular 28 days interval, but she did have heavier than usual bleeding during her last two menstrual periods. No medication, no history of bleeding problems, including during an uncomplicated appendectomy at the age of 10 years and during delivery of two children. She didn't have any bleeding problems. No family history of bleeding problems. Exam shows scattered petechia over the trunk and upper lower extremity. There is fresh and clot blood in the nares with continued using of blood. Hemoglobin low, leukocyte, I guess normal differential. Platelet is low. Exam of the bone marrow aspirate shows megakaryocytes. Next step in management.
Is it ITP?
What is ITP again? Into
Idiopathic thrombocytopenic, not purpura. Yes, bleeding problem, but no bleeding disorder.
platelet count is low, hemoglobin is low. So platelets are being consumed
Maybe
and
ITP.
hemoglobin also is being. It looks like DIC. That cannot be DIC. Everything
No,
is.
it's
Mm,
in DIC. PT would be high, platelet count
I
would
mean,
be low.
they didn't give PT here.
Uh,
Um.
you can say, mm,
Uh, mm, I feel like it's DIC, but even if it's DIC, this doesn't even. And she has
I
petechia.
I was what I am talking about that was correct, like ITP. Now think about ITP.
My brain is not working. What was ITP again? It.
Immune
Well,
thrombocytopenia or idiopathic
immune
thrombocytopenia.
immune thrombo. Oh, the antibodies against the. Oh, then it's corticosteroid. Okay, ready.
Okay, so this patient has mucocutaneous bleeding and low platelet count. This patient has a mucocutaneous bleeding and a low platelet count with increased megakaryocyte concentration. With increased megakaryocyte concentration on bone marrow biopsy. These symptoms are fairly pathognomonic for ITP, idiopathic thrombocytopenic purpura. This is thought to be mediated by antibodies to the platelet. Thought to be mediated by the antibodies to the platelet. An initial step for treatment is steroid therapy. Methotrexate therapy has not been shown to have an effect on ITP. Interventions on the spleen are reserved for severe cases that persist despite medical treatment and have relapses. The patient has new diagnosis and thus deserves a course of steroid to see effect. Okay.
Okay, 77 man brought by his wife follow-up exam 3 weeks after an episode of right middle lobe pneumonia. The pneumonia is improving with antibiotic. 3 months ago, he had a similar episode. His wife says that he swallows his food well, but he has had slight increase in his chronic cough after meals. Has multi-infant dementia, small for 40 years, but he quit 15 years ago. Never had COPD. Bronchi are heard over the right mid-lung field on auscultation. Diaphragm has poor excursion. Speech is mild dysarthric. Mini-mental is low. Which of the following most appropriate next step in management?
These are
those who have here.
Is it aspiration type of pneumonia?
Ready?
Yes. Okay. So the recurrent episodes of pneumonia, along with a history of increase in cough after meals, should significantly increase in suspicion for chronic aspiration secondary to dysphagia and warrants further evaluation with swallowing study. Until results of until results of a swallowing study are available, dietary recommendations should not be made as it will significantly influence the choice of the diet. While a CT scan of the chest may be appropriate to ensure resolution of his pneumonia, the timing of the study is more typically done in 6 to 8 weeks range after initial imaging in order to give ample time for the acute process to resolve. In the absence of concern of central airway obstruction leading to post-obstructive pneumonia, the fact that patient is improving on current therapy, a bronchoscopy is not necessary at this time. In the absence of bronchospasm, bronchodilator are not likely lead to significant benefit in this patient. Okay.
Okay. Healthy 39-man German descent comes to for routine exam. He had a cholecystectomy at 25 years old. He has had several episodes of mild jaundice over the past 10 years that resolved spontaneously. He appears healthy. Exam shows no abnormalities except splenomegaly. Hematocrit is 39. Mean corpuscular hemoglobin concentration is 36. And MCV is 80. So I'm guessing hematocrit is low. Direct antiglobulin comes test is negative. Blood smear shows erythrocyte with loss of central pallor. Ah, the cause of the patient anemia. Wait, let me see. MCHC is, let me double check. MCH is normal actually.
MCHC is normal.
Normal. Hematocrit is actually hematocrit is actually normal. Is low, sorry. Red blood cell. There will loss of central pallor. Congenital interfolio reductase deficiency. Uric acid
Is
concentration.
it after cholecystectomy? Is it Gilbert syndrome?
So cholecystectomy was like 25 years ago.
Okay, cholecystectomy.
Oh, it was a while ago. I mean, I don't know, but it doesn't look like that.
German descent. Blood erythrocyte. Okay, erythrocyte with loss of central pillar. It is spherocytes.
Spherocytes, maybe, yeah. There's lots of
Hmm.
cells.
Okay, it is spherocytes. So spherocytes. So is it like what can I say? Hereditary spherocytosis.
Yeah, you got the thing, but yeah.
A loss of central pallor. Okay, I think that I got it.
Ready?
Yes, it is hereditary spherocytosis. Yes. Okay, this patient with mild anemia with symptoms of intermittent hemolysis that are manifest by bouts of jaundice Given the patient's Northern European descent, hereditary spherocytosis is most likely diagnosis is caused by alteration in the genes related to the membrane protein. There is no evidence of any autoimmune disease, and the negative results of the Coombs test make autoimmune conditions unlikely. The patient is in his 30s and takes no supplemental folic acid, so a history of congenital iodine reductase deficiency is not likely. There is no evidence of decreased erythropoietin concentration, and the patient has no known risk factors such as chronic kidney disease. There is no reason to think the patient is deficient in folate or vitamin B12 because there is no evidence of macrocytosis. Okay,
Can you keep going?
yeah.
Mhm.
Glucose 6-phosphate dehydrogenase deficiency is unlikely in patients with Northern European descent and would manifest after taking substance known to stress oxidative reduction systems such as sulfa antibiotics. Globin chain mutation would result in smaller cells, typically a more profound anemia and autosplenectomy at this stage rather than splenomegaly. Lead poisoning is not likely given the information in the vignette, and while pyruvate kinase deficiency certainly fits the clinical picture, it is usually more problematic in children and requires transfusion if the phenotype is significant. Neither neither has been included in the vignette and making spherocytes more likely. Okay.
What was pyruvate kinase again? It was like
Pyruvate
what,
kinase deficiency.
what was the usual question for that? Like you know how GCSPD is like the drug that you give and causes the oxidative stress and all that. What was pyruvate kinase again?
In pyruvate kinase deficiency and the G6PD deficiency. In G6PD deficiency, there is presence of Hinge body, as far I remember, and in pyruvate kinase, no Hinge body. Like you want something in the question pattern.
Yeah, the question pattern. Like you
I
GCSPD.
haven't dealt pyruvate kinase.
No.
I haven't. Maybe there is question, but I don't remember.
Yeah. Okay. 47 men comes to physician because 1 month history of progressive swelling of both legs and generalized weakness. He says he now has some difficulty performing his usual activities. Last year, he received the diagnosis of Hep B and C. He has long-standing history of IV drug use. He refused treatment for Hep C and currently takes no med. He's not in acute distress. BMI is pretty low. Temperature fine, pulse fine, respiration fine, BP high. Cardiopulmonary exam is fine, abdomen fine. There is no hepatomegaly, muscle strength normal. Labs, hemoglobin, I believe that's low. Leukocyte fine, platelet fine. Urea, let me check my notes. It's high. Creatinine high. Albumin fine. Total bilirubin fine. AST high. ALT high. Urine, blood 4 plus, and protein, blood 3 plus, and protein 4 plus. Microscopic exam of urine shows numerous RBCs, which are mostly acanthocytes. Forgot. With irregular membrane protrusion. Most appropriate next step in diagnosis. What am I? Sorry. Uh, he's having swelling of both legs and weakness.
Man, no long standing.
I've studies in. I forgot what is the diagnosis here.
Is it that box like hematuria, like 3 plus? When I find something, I try to match with the box.
Ah,
Very wrong idea, I know that,
which of
but
these
I have nothing to
acanthocytes?
do.
Yeah, I I don't even know what the diagnosis is. No hepatomegaly, but his BMI is so small, it's so low. Generalized, blah blah blah. Ah,
Is it glomerular hematuria or non-glomerular hematuria?
mm, he has hypertension, so maybe
3
compared with,
plus, maybe I'm thinking it is glomerular hematuria.
but it's not. There's no cast. Okay, I guess. I guess. So
Yes, in glomerular hematuria, a cast may be present. RBC cards, these more RBC.
protein electrophoresis. Blah, blah, blah. I don't know. Wait,
I think that okay, you give your answer. Let's see
ready?
what happens. Yes.
Oh,
Okay. We are
oh,
out of everything.
yeah, I'm just. I have
We
no
are
idea
roaming
what.
around different things. Okay.
No, but you're right. It seems like it's glomerulonephritis.
But I give cystoscopy.
Oh,
The patient has untreated hepatitis C. This
oh,
patient has untreated hepatitis C. 3 plus protein, 4 plus protein, presence of blood, glomerulonephritis. This patient has untreated hepatitis C and now symptoms of nephrotic syndrome with significant edema and marked proteinuria and hematuria acanthocytosis. Most likely seen in glomerulonephritis, hepatitis C can lead to significant renal disease such as membranoproliferative glomerulonephritis, membranous nephropathy, mixed cryoglobulin syndrome, polyarteritis nodosa given is elevated creatinine and a hematuria. A renal biopsy is warranted at this time given the severity of his symptoms and elevated creatinine. A delay in the diagnosis with repeat labs at a later time is inappropriate as the disease is likely to continue to worsen. Urine protein electrophoresis is useful in the evaluation of the monoclonal gammopathy in such monoclonal gammopathy monoclonal gammopathy in disease such as multiple myeloma and amyloidosis, but would not have a role in the evaluation of the patient. Okay. Oh, you want me to read the other options too?
mm, no.
Okay, next.
Oh. 37 one man comes to ED because vomiting for 3 days. He says that he cannot hold down liquids or solids. For the past month, he has had early satiety and has not been eating as much as he usually does. He has 2 year history of peptic ulcer disease, diagnosed by open endoscopy. Infection with H. pylori was successfully treated with clarithromycin, amoxicillin, omeprazole, and bismuth therapy. Since then, he has had intermittent epigastric pain, for which he takes cimetidine when he remembers to do so. He appears ill and anxious. Temperature fine, pulse high, BP is a bit low. Physical exam shows dry mucous membranes and a flat, soft, non-tender abdomen. Set of lab abnormalities most likely in this patient. He's vomiting. So you vomit acid and you poop base. You vomit acid.
Mm, Is it GOO?
What is GOO?
Gastric outlet obstruction. Okay, don't think on that. Like vomiting is like uh, removing the hydrochloric acid, like chloride, isn't it?
Yeah, so if you remove, then sodium will be
Mm,
high and potassium will be
Wait,
low.
vomiting, valage, vomiting.
Okay, ready?
Yes,
Okay. It was between C and D. Let's see.
it
Yep,
is D.
got it.
Okay, it's GOO, gastric outlet obstruction. These patients' symptoms strongly suggestive of GO, gastric outlet obstruction, a known complication of the peptic ulcer disease. A known complication of the peptic ulcer disease. Uh, though they though this has decreased significantly in the modern era of the treatment of the H. pylori, malignancy is now much more common cause of gastric outlet obstruction. So malignancy is one of the common cause of gastric outlet obstruction. Regardless of the etiology of the gastric outlet obstruction, recurrent vomiting, which leads to increased losses of the hydrochloric acid from stomach contents, leading to both increase in the serum pH as well as decrease in the chloride volume, depletion, dry mucosa, and metabolic alkalosis, can lead to increased potassium excretion in the kidneys, resulting in hypokalemia. Okay,
Okay, we have done. If you want to start the next one today or just tomorrow.
what do you want to do?
It's up to you.
Let's take a break for 5-10 minutes then, and
And then start the next one.
yes.
Okay.